Yeah. Hi, very good morning. So, how are you all doing? Hi, Purvel. Think it's evening for you. Yeah. Hi, Tanu. Good morning. Hi, Prithvi. Abba, Prerna, Srish, Shivaranjani. Hi. Hi, Dhanlakshmi. Very good morning. So, I shared a few patients last night. I hope you have gone through them, right? So, we'll discuss these multiple choice questions, right? So, we have five. We'll proceed directly with our MCQ discussion, and as we have been doing for the past 2 weeks. And today evening around 8 p.m. we shall have one virtual classroom session also. So coming to the first question, the most common oral problems occurring after radiation and chemotherapy are mucositis, infection, pain, and bleeding. So we have two statements given here. So that's the first statement. And the second statement is the oral cavity is irradiated during the course of treating radiosensitive oral malignant tumors, usually squamous cell carcinoma. So we have options. The first statement is true, second is false. First is false, second is true. Both statements are true, both statements are false. So, to answering this question, we shall have a brief discussion pertaining to the same. Hi Soumya, good morning. So, which of the following statement? It's not actually assertion reason type, so we have two statements here. So, which statement is true and which is false? Statement 1 is the most common oral problems occurring after radiation and chemotherapy are mucositis, infection, pain, and bleeding. And second statement, the oral cavity is irradiated during the course of treating radiosensitive oral malignant tumors, usually squamous cell carcinoma. Yes, Dhanlakshmi, Prithvi, you say option B. That is, first statement is false and second is true according to you. Okay. So we have unanimous answer more or less. Okay, first of all, when do you go for radiotherapy? So, what are the criteria when we prefer radiotherapy or surgical therapy? So, there are a few criteria which have been mentioned. So, when we are going for radiotherapy, so radiotherapy is usually preferred in cases where the lesion is radiosensitive. So, that's obvious, right? Invasive type, and when it is not accessible to surgery. So there are some criteria such as this when we go for radiotherapy. Most importantly, the lesion has to be radiosensitive and it should be deeply invasive, and also it is not accessible to surgical excision or surgical removal. In such cases we go for radiotherapy, isn't it? Along with that, if this is an advanced stage, any lesions, so it can be carcinoma or sarcoma, anything which is in advanced stage, obviously we can't prefer surgery, we go for a radiotherapy, isn't it? And then when you're going for radiotherapy, we have something called as fractionation. Just write down here. Fractionation. So fractionation is nothing but dividing the total radiation dose into multiple smaller doses and then delivering to the lesion, right? So the advantage with fractionation is the fact that because of this fractionation, what happens is there is increased cellular repair. And this cellular repair is seen better in case of normal cells compared to cancerous cells. So in the process, more amount of cancer cells can be destroyed using fractionation. And also the second reason which has been cited as an advantage while proceeding with this fractionation therapy is there is increased oxygen tension within the tumor mass. As a result, it makes the tumor mass more sensitive, more radiosensitive, right? So the first advantage, as we have discussed, is there is increased cellular repair. And also increased oxygen tension within the tumor mass. So because of these two reasons, there is increased destruction of tumor, making it more radiosensitive. So this is fractionation, right? So fractionation is nothing but dividing the total radiation dose into multiple smaller doses and then delivering it to the lesion of choice, right? So these are some of the advantages we have with fractionation, and this is where we go ahead with your radiation therapy. So that's obvious, right? Now, what are the effects of this radiation on various tissues? First, starting with oral mucous membrane. So what happens usually when you go for radiation therapy in case of oral cavity, whenever there is squamous cell carcinoma, usually in the process of treating squamous cell carcinoma in oral cavity, we go for radiation therapy. So what are the side effects? First, we'll see the effects on oral mucous membrane. So what are the effects you're going to see on oral mucous membrane? Yes, you can try answering it. It's a direct question, right? So what are the effects you see on oral mucous membrane? Good. So obviously, as Purvel said, it is mucositis. There can be prolonged radiation therapy can lead to atrophy, and also there can be formation of pseudomembrane, isn't it? And also there can be secondary infections like candidal infections, etc. So these are some of the effects which we see on oral mucous membrane. Good. Yes, osteoradionecrosis in case of bone. Its effect on bone. There can be osteoradionecrosis where there is decreased vasculature, especially in dense bones like mandible, where the vasculature is already minimal. So because of this decreased vasculature or effect on vasculature, there will be more chance for infection, osteoradionecrosis. Good. Yes, on salivary gland. And also it's mentioned that endosteal layer is affected in bone, and osteoblastic and osteoclastic activity is also inhibited. As a result, it's more prone for necrosis. On salivary glands, so there will be decreased salivary secretion leading to xerostomia. And taste buds. The acuity of taste, ability to taste various substances decreases, right? And what about teeth? If the teeth are in developing stage, their development is affected, but adult teeth, once they are fully formed, they are radio resistant, completely resistant to the effects of radiation, right? Yeah. And also, you might have heard of radiation caries, right? Because of xerostomia, there can be a greater chance for radiation-induced caries. In the sense, because of decreased salivation, decreased self-cleansing action, teeth, there is more shift towards acidity in the oral cavity leading to caries, right? So that's radiation caries. Yes. Good. So these are some of the changes here. And also, as you mentioned, it becomes avascular. So these are some of the changes which you can anticipate in case of radiation therapy, right? Now, let's come back to the question again. The most common oral problems occurring after radiation chemotherapy are mucositis, infection, there can be even pain and bleeding in some cases. and the oral cavity is irradiated during the course of treating radiosensitive oral malignant tumors, usually squamous cell carcinoma. So both statements are true. It's not option B, it is option C. Both statements are true. Sorry if you're not able to say this. This is fractionation, right? Yeah. Anyways, we'll make some adjustment in order to avoid this reflection of light from the next session. So option C is the right answer. Okay? So this is in brief a few important points pertaining to radiation therapy, right? Now, anyways, we'll have a summary at the end of this video. Okay, we'll just proceed to the second question. All of the following are considered to be the basic principles for occlusal adjustment except option A, the maximum distribution of occlusal stresses in centric relation. Option B, the forces of occlusion should be borne as much as possible by the long axis of the teeth. Option C, when there is a point to surface contact of flat cusps, it should be changed into surface to surface contact. Option D, once centric occlusion is established, never take the teeth out of centric occlusion. So these are the four options we have. So all of the following are considered to be basic principles of for occlusal adjustment except. So which is the exception? So what are the basic principles for occlusal adjustment? And those who are attending our live session for the first time, we have already shared all these questions in our Google group. If you want to join our Google group, you can just drop a mail at proudtoberentist@gmail.com. I'll send you a link. You will be getting regular updates from our academy in our Google group, right? So choose the right answer of this second question. So what are the basic principles for occlusal adjustment? You can give it a try. Yes, then Lakshmi, Tanu, Prithvi, Purvel. Yes. Purvel says option B. Hi Shruti, good morning. Yes, Nisrin. Yeah. The four basic principles of occlusal adjustment. Just make a note of these four basic principles. Already you have three principles mentioned in the options. So, the first basic principle in occlusal adjustment is maximum distribution of occlusal stresses. Maximum distribution of occlusal stresses in centric relation. So that's the first basic principle. And second principle is the forces of occlusion should be diverted along the long axis of tooth. right? So for example, you have any tooth, the forces have to be directed along the long axis of your tooth. That's the second principle, right? So forces of occlusion should be borne as much as possible along the long axis of tooth. And the third principle is when there is a surface to surface contact of flat cusps, it has to be changed from surface to surface to surface to point contacts for better stress distribution, right? In case of flat cusps, the surface to surface contact has to be changed to surface to point contact, right? So assume that you have two cusps here. So you should have surface to point contact. And the fourth principle says that once centric occlusion is established, it should not be diverted away from it. Once centric occlusion is established, never take the teeth out of centric relation. And in centric relation, there has to be maximum stress distribution, right? So these are the four basic principles for occlusal adjustment, right? So you can just make a note. Now the answer is obvious, right? So option C says when there is point to surface contact, it has to be changed to surface. So the reverse is true. Okay. So these are the four basic principles for occlusal adjustment. So option C is the right answer. Okay. Yeah. Move on to the third question. The purpose of periodontal dressing includes all of the following except option A, stop persistent bleeding, option B, maintain the sutured position of the flap, option C, improve patient comfort, option D, prevent mechanical injury to hearing tissues. So what is the purpose of periodontal dressing? So you need to find out the odd one out. The purpose of periodontal dressing includes all except. Yes, Purvi. Dhanlakshmi, good. Yeah. So what are the various objectives or functions of periodontal dressing? Why do you give periodontal dressing? That's true. They're not used for stopping bleeding. Bleeding has to be arrested, hemostasis has to be achieved, and then we proceed with periodontal dressing, right? And periodontal dressing prevents secondary bleeding by stabilizing the primary clot, which is being formed initially. Good. So option A is the right answer. So what else are the functions of periodontal dressing? So one is they prevent secondary bleeding, helps in stabilizing mobile teeth, also helps in stabilizing the flaps which have been positioned back into their normal positions. It helps in stabilizing flaps, can be used in mobile teeth, right? Helps in stabilizing mobile teeth. Prevents post-operative bleeding also, as we discussed. Prevents post-op bleeding by stabilizing the initial clot formation, and also protects the area from external stimuli or irritants. Right? What else? So in this way it protects the wound from the external stimuli and promotes healing, right? So these are some of the functions of periodontal dressing, right? So it helps in stabilizing mobility, stabilizing post-surgical area, the flaps which have been placed back to their normal position, prevents post-op bleeding, protects the area from external stimuli or from various irritants, and thereby ultimately promotes healing. Okay, so we have eugenol based and non-eugenol based. Copac is an example for eugenol or non-eugenol. Copac. Hi Ramesh, very good morning. So what is Copac and what does it contain? So we have alternate answers, non-eugenol, eugenol. So Copac is non-eugenol based, right? Copac is non-eugenol based. One tube contains zinc oxide and the other tube contains fatty acids. It's mentioned as colophony resin and chlorothymol, which acts as a bacteriostatic agent, right? It's a non-eugenol based Copac. Okay. I'll just mention the composition also. One tube contains so it's available as two tubes. Zinc oxide, which is the principal ingredient, chlorothidol, a fungicide. The other tube contains chlorothymol, which acts as a hemostatic agent, and colophony resin. I'll just spell this so that it will be convenient for you to note down, right? It's a fatty acid. Chlorophony resin is a fatty acid. Chlorothymol is a bacteriostatic agent. Not hemostatic, bacteriostatic. I'll just read out these things for you, right? I hope it's visible. Yeah. So non-eugenol, Copac is a non-eugenol base. It's a name of a brand. Okay, Copac is a brand name. One tube contains zinc oxide. You have even oil and chlorothidol, which is a fungicide. The second tube contains chlorothymol, which is a bacteriostatic agent, and colophony resin, which is a fatty acid, right? So this is a non-eugenol based pack, periodontal pack. And also you have various zinc oxide eugenol based packs, right? So this is in brief, periodontal packs. Yeah, it is non-eugenol based. Hi Preeti, a very good morning. So option A is the right answer. Okay. So as all of you mentioned, bleeding has to be arrested before placing your periodontal dressing. Now coming to the fourth patient. A 4-year-old child presents with acute pain associated with a primary mandibular second molar that has a large carious lesion with pulpal involvement. Radiographically, there is a periapical pathology on the distal root. The child is very cooperative and is able to tolerate long appointments. What is the preferred choice of therapy for the primary mandibular second molar? Incision and drainage, pulpotomy, pulpectomy, extraction. So there is a primary mandibular second molar which is having carious lesion, and periapical changes are also evident, especially the distal root. Patient is 4 years. The age is very important, and most importantly, he or she says, the person who said this patient says, patient is able to tolerate long appointments and the child is very cooperative. So which is the best treatment option for the given patient? Pulpotomy, pulpectomy, extraction, incision and drainage. Yes, then Lakshmi, Shivaranjani, Preeti, Angel, hi Angel, Purvil, Prithvi, Shruti. If the age of the patient is even more like 6 years or 7 years, maybe we'll think of extraction. And if the patient is non-cooperative, maybe we'll think of extraction. But 4 years, you still have time for eruption of your, obviously your primary molars are being replaced by premolars. So the most important thing is which acts as a best space maintainer. We have various appliances, various devices to maintain space. So which acts as a best space maintainer according to you? We have a question on this also, right? So Prerna, you say pulpectomy. If associated with swelling and drainage, okay, swelling, then you drain it. Okay. In fact, Prerna, incision and drainage is always not performed in cases of your swelling associated with a tooth. In fact, opening up your tooth or performing access opening also comes under drainage, right? So it's always not mandatory. So yes, a natural tooth is the best space maintainer, as you all rightly mentioned, right? Natural tooth. No matter how many devices you have, natural tooth acts as a best space maintainer. Isn't it? So, in this case specifically, and moreover you have periapical lesion. If there is no periapical lesion, only carious exposure of pulp with symptoms, maybe we can plan for pharmacosol pulpotomy. But there is involvement of pulp, periapical changes, so pulpectomy followed by filing with H files, and then the best available material for obturation is obviously zinc oxide regional, which helps in, which also resolves simultaneously with your root, right? And also remember, when you're going for pulpectomy, we have certain indications and contraindications. We'll discuss that in detail now. But before that, in this particular case, a 4-year-old patient, carious exposure of second molar, primary molar. So pulpectomy is the best choice we have. And moreover, the patient is very cooperative and is able to tolerate long appointments. Right. So natural tooth is a best space maintainer. And coming to the indications of pulpectomy, obviously when there is exposure of pulp, whenever there are periapical changes, all this come under the indications, right? And also when there is no pathologic root resorption, right? So even that's an indication for your pulpectomy. So whenever there is a tooth which is restorable with a crown, whenever there are periapical changes, and whenever there are cases where there is suppuration, I mean, swelling, pus discharge, even those cases are indicated for pulpectomies, right? So you can just make a note of these points. A tooth that is restorable with a crown is an indication for pulpectomy. If in case there is pulp exposure with adequate crown structure, obviously you go for pulpectomy and restoration with a stainless steel crown. And when there is no pathologic root resorption, it's also an indication for pulpectomy. And whenever there is periapical changes, radiographically, we go for pulpectomy. And whenever there is suppuration. And most importantly, there has to be adequate bone and the developing tooth should be separated well from the primary tooth in which you are performing pulpectomy, right? Now coming to contraindications, when more than 2/3 of root is resolved, of deciduous tooth, when more than 2/3 of root is resolved, then obviously you go for extraction, right? Yeah. And also tooth in which there is inaccessible canals or because of the complex morphology, even that can be considered as a contraindication for your pulpectomy. And when the floor of pulp chamber is directly entering and when there is bifurcation radiolucence or furcation radiolucence extensively, obviously it will go for extraction, right? So floor of the pulp opening into furcation and radiographic indication of external resorptions also is a contraindication for pulpectomy, right? So once you understand indications, obviously you can make out the contraindications also. So these are some of the indications and contraindications. Just keep them in mind and make a note of them as well, right? So in such cases, as we discussed, pulpectomy would be the ideal choice in this case, right? So option, which option is it? Yeah, option C is the right answer. Okay, now let's move on to the final question. During the serial extraction case, which teeth are not typically removed or which teeth are spared in serial extraction? So you have options: primary canines, primary first molars, first premolars, primary second molars. We have discussed serial extraction in detail in one of the virtual classroom sessions. You can refer that for different types of different methods proposed by different authors, right? And also the sequence, why we follow a specific sequence, right? So during a serial extraction case, which of the teeth is spared? Primary canine, primary first molar, first premolars, primary second molars. And can you generalize and tell me the sequence of extraction of teeth? Yes, it is primary second molar. So primary canine C are extracted and then we'll even extract primary first molars to accelerate the eruption of your premolars before canines, and even premolars, first premolars are extracted, right? Yeah. So primary second molars, option D is appropriate answer. Yes, we have different sequences. Good. CD4, D4C. Yeah. So we go for this serial extraction whenever there is arch length and tooth material discrepancy, right? When there is discrepancy between arch length and the size of the tooth. So whenever serial extraction is performed, the duration or the time lag between the serial extraction of one tooth from the other has to be 6 to 15 months, right? So 6 to 15 months is the interval between extractions, and to aid in support and retention, a lingual arch has to be placed in the lower arch and Hollis appliance in the upper arch for helping or for assisting in retention, right? After extraction, to maintain the arch length, we place lingual arch in mandible and Hollis appliance in maxilla. Yes, Preeti? Good. So when the arch length, arch space deficiency, the permanent dentition or 10, that's fine, right? Yeah. So this is in brief a few key points which I wanted to discuss, covering various topics. radiology, pedo, surgery, ortho, right? So we'll just have a brief summary for 5 minutes, all the important points which are discussed, and then we'll conclude, right? So as we have seen, first we have discussed indications of radiotherapy and what is fractionation. The objective of fractionation is very important. And also, what are the effects of radiation on the oral cavity, right? On the oral mucous membrane, taste buds, salivary glands, teeth, bone, and also what is xerostomia, radiation carriers and all. And also we discussed few basic principles pertaining to occlusal adjustment, right? I'll make a note of these basic principles, and also the objectives of periodontal dressing, what is co-pack and the composition of co-pack. And also we have discussed about the space maintainers in the process, and most importantly we have gone through the serial extraction topic as well, right? So already we covered serial extraction extensively in one of the videos previously. You can refer that for more information. And pulpectomy in primary teeth, the indications as well as contraindications of pulpectomy, and case-based questions. So it depends upon your understanding of theory and how you proceed practically, right? So case-based questions also, right? So these are some of the important points, and if you have any questions, drop them at proudtobedentist@gmail.com, right? Yeah. Yes. So hope your preparation is going on fine, and we'll try to cover as many topics as possible in the coming 3 live sessions, okay? So we'll have one virtual classroom session tonight at 8 p.m. and again tomorrow morning we'll have image-based questions at 5 o'clock, and tomorrow night again at 8 p.m. Indian Standard Time we'll have one textbook discussion, converting all of them into virtual classroom sessions and using board as much as possible, so that it will be much more clearer. And based on the feedback I'm getting, I've been doing this, right? And you have any suggestions to make, you can always drop them at proudtobedentist@gmail.com, right? Yeah. So it's around 30 to 35 days. Hope you're giving your best. So that should be your only focus. Just give your best, use maximum time for preparation, and also seriously consider incorporating these retrograde schedules. And you can send me your schedules, right? We can have some discussion and let's see how you can improvise. I mean, once you start implementing these retrograde schedules, right? You'll obviously know which areas you have to improve. So they mainly help in self-analysis, and I've been getting few mails regarding the same. Obviously, you'll feel the difference, right? So use them, try to use maximum time for preparation. There is nothing to get demotivated. You have plenty of time. Use this time for your benefit, right? And also I mentioned about active learning. So please do give importance to active learning. So put the effort in referring, understanding, and it's not just concept based. Even memory based topics can be learned well, can be memorized well through active learning. If I give you some value, for example, if I ask you, if I mention these 4 points, these are all memory based, right? You might just listen, but you'll remain a passive learner. But if you put the effort in making notes, understanding them, then it will be easier for you to memorize, or it helps in establishing in you, right? It can be concept based or memory based. Even various values which I give, it's just I'm giving you values, you're just taking them passively. Make a note of them, and if you have any doubt, refer in a standard literature, then that will be imprinted in your brain for sure. It will be everlasting, long lasting for sure. So it can be either concept based or memory based. So put the effort in searching, put the effort in making notes, and put the effort in revising. Obviously going to be an active learner, and this will help you to improve your confidence levels, right? So I made this video recently, and try implementing that, and don't just be a passive learner, and don't just try to obtain only right answers. That's not going to do any good for you, right? I hope it's clear. See you again tonight at 8 p.m. Right. Bye. Have a nice day. Yes, you're all welcome. Bye.